Well, I was about to whine and say that I always got put on the wrong side of a populist argument. Maybe the world's changed a little bit. So anyway, I get the pleasure of debating today my mentor from Mayo Clinic and colleague for many years, Bill Tremaine, and usually he kicks my buns on stuff like this, so we'll see what happens today. But here's how I'd like you to spend a few minutes thinking about this topic. So what is the argument for escalating therapy in patients with moderate endoscopic findings of ulcerative colitis who are clinically asymptomatic? So you've heard a lot of times in recent years, our drugs aren't that good and it's not feasible. So I want to show you some data that maybe it is feasible. And then I'd like to make the point that it's associated with a reduced rate of colectomy and an increased rate of steroid-free remission over the course of a year. It's associated with a reduced rate of colorectal cancer. And finally, I want to just spend a little time making the point that it's logical and obviously the right thing to do. And I'll come back to that. So first of all, the feasibility. So I talked a little bit in the earlier session about this evolving concept of treating to target. So the idea is you take a patient with active ulcerative colitis or Crohn's disease, you apply some risk stratification so that you're making therapeutic decision-making in the larger setting of what you think the patient's prognosis is. Then you make a therapy. If you see active inflammation, you add some kind of therapeutic intervention. And then the idea is you would reassess inflammation, typically with endoscopy, within about 6 months. Make sure the patient has achieved your resolution of inflammation goal. And if they haven't, circle back through and figure out, is there something else I can do to optimize? Can I adjust the dosing of the drug to trough levels? Can I add an immune suppressive? Can I switch biologics? What can I do to bring the patient into not just a clinical asymptomatic remission, but a biologic remission with mucosal healing? So coming back to this idea that our drugs aren't good enough, so when I moved to San Diego a few years ago, I've looked back now for some of the first patients that I saw in my practice, and we've got some follow-up on to see what happens. We had a series of patients with ulcerative colitis who came into the practice, and it's my habit when patients are newly into my practice to have a basal level of examination. So most of the patients got a baseline scope, and then we had a series of patients who had several scopes based on the findings. And I want to focus on 45 patients who had inflammation at their baseline endoscopy. And so patients went through a series of procedures, up to 5 procedures in a handful of patients. And each of these, you treat, reevaluate, and if there's still active inflammation, you escalate therapy. And you can see that the yield picks up, and if you keep going at this, eventually you can get a lot of patients into remission. And so here's some of the things we did. We introduced 5-ASA, we escalated the dose, we added steroids, we added an anti-TNF, we switched or optimized the anti-TNF, or we added an immune suppressive, sometimes more than one of these things. So all the things you know you can do in clinical practice, and it's what's different from a clinical trial where you're fixing everything except for the intervention. So clinical practice is better than a clinical trial because there's a lot more things you can do. So here in my referral center kind of train wreck practice, here's what we were able to achieve: endoscopic healing on the left and histologic healing on the right. So this is the other argument that people make sometimes. Okay, well, you got to endoscopic healing, but there's still histologic inflammation. Not so. In a difficult referral practice, we could get over half the patients to full histologic remission, although we were really titrating to endoscopy remission. And then what do you think the predictor is? So this is so self-evident. The predictors in multivariate analysis, it didn't matter what drugs you were using and all of that, the predictors for getting to mucosal healing were repeat endoscopy, and if you still have active inflammation, make a change in therapy. So here's some of the patients who didn't get a change in therapy versus those who did, and you can see that it makes a big difference. So that shows you that, don't tell me it's not feasible. It is feasible. You have to agree, you and the patient, that you're going to pursue that strategy. So the next thing is looking at the clinical benefits associated with this. So here's a population-based study from Norway, published a few years ago, that took patients with newly diagnosed ulcerative colitis, and then they looked to see what had happened from an endoscopy standpoint at the end of the first year, and stratified the patients into according to whether they had achieved mucosal healing and whatever therapy they got in the community setting or not. And you can see that the colectomy rates over the next 6 or 7 years were quite low in patients who eventually achieved mucosal healing after a year of therapy, whereas the patients who didn't achieve mucosal healing had quite high colectomy rates. So that's population-based data. What about clinical trial data? So here's the infliximab pivotal studies. We recruited patients with moderate to severe ulcerative colitis, and they were randomized to infliximab or placebo. Recall that patients had to come into the trials with a 2 or a 3, so you're looking for moderate to severe clinical symptoms plus endoscopy, and then we looked to see what happened over time. So if you, at 8 weeks, if you achieved a downgrade from a 2 or a 3 to a 0 or 1, and remember what we're debating is a patient that has a 2, not a 1, a 2. So if you downgraded from a 2 or a 3 to a 0 or a 1, you had a low rate of colectomy, whereas you really had an appreciable rate of colectomy if you maintained a 2 or a 3 after 8 weeks of induction therapy. So it looked like achieving endoscopic remission mattered in this trial. And then here's a more subtle distinction. So this looks at steroid-free clinical remission over the year. So if you got all the way to 0, 46% of the patients were in steroid-free clinical remission, and you lost about 12% if you got to a 1, and then it went way downhill if you got what we're talking about, a moderate, that very few of those patients were in steroid-free remission at a year. So it looks like it makes a difference clinically if you treat to the target of mucosal healing. Well, and then there's this issue of colorectal cancer. So here's an interesting study from Matt Rutter and the St. Mark's Hospital in London, which really pioneered our modern concepts of surveillance colonoscopy in patients with ulcerative colitis. And you're all familiar with the classic risk factors of disease extent, presence of PSC, duration of the disease, a family history of colorectal cancer. But look at these measures of inflammation. So there were independent benefits of achieving mucosal healing as measured by either colonoscopy or histology. And the histology was even higher, but the endoscopy remission was really useful. And Dave Rubin and his colleagues at the University of Chicago have confirmed these data in subsequent years. So finally, it's logical and it's obviously the right thing to do. So those of you who were here last night heard Gary Lichtenstein talk about that some things are logical, and for instance, you don't necessarily need a randomized controlled trial to figure out that you should have a parachute when you jump out of an airplane. Well, I had no idea Gary was going to do that, but I'm going to come back for emphasis. So this is one of my favorite studies in the medical literature. A parachute used to prevent death and major trauma related to gravitational challenge, a systematic review of randomized controlled trials. So the objective of this systematic review was to determine whether parachutes are effective in preventing major trauma related to gravitational challenge. The design was a systematic review of randomized controlled trials. They went to all the usual data sources to get evidence-based data. The study selection identified studies showing the effects of using a parachute during free fall. And the main outcome measure was death or major trauma, defined as an injury severity score of at least 15 points. So the results, the authors were unable to identify any randomized controlled trials of a parachute intervention. And they concluded that as with many interventions intended to prevent ill health, the effectiveness of parachutes has not been subject to rigorous evaluation by randomized controlled trials, and the advocates of evidence-based medicine have criticized the adoption of interventions using only observational data. So be careful when you listen to Bill in a few minutes. And we think that everyone might benefit if the most radical protagonist of evidence-based medicine organized and participated in a double-blind, randomized, placebo-controlled crossover trial of the parachute. So you don't need a randomized controlled trial to determine that a parachute is the right thing to do. And I'm asking you as the audience, before you vote at the end of this session, do you really need a randomized controlled trial to determine that colon healing is the right thing? If you're the patient, what do you want? The colon on the left or the colon on the right? Thank you.